morning, everyone. Today I am talking of the assessment of the risk of obstructive sleep apnea with the activity of thyroid eye disease. No financial state. As we all know that thyroid eye disease is an autoimmune disorder which presented mainly with the proptosis, chemosis, the eyelid retraction, and also the restrictive myopathy and inflammatory signs, and rarely with the optic neuropathy and the corneal ulceration. Obstructive sleep apnea is also a common disorder that is characterized by the repetitive narrowing and collapse of the pharyngeal airway, and this is associated with the comorbidity including excessive daytime sleepiness and increased risk of cardiovascular disease. So the both shares a very common pathophysiology. So we all are aware of this very complex kind of the pathophysiology in the thyroid eye disease that lead to the autoantibody activation of the orbital fibroblast with the cytokine upregulation and lead to the increased volume of that orbit leading to the proptosis, diplopia, and the restrictive diseases. So interleukin 16 is the most important cytokine that also enhances the adipogenesis. So coming to the, there's a Habib et al. Has a study that in the retrospective observational studies has shown the association of the risk of obstructive sleep apnea and thyroid eye disease compressive optic neuropathy. And recently, the Godfrey et al. In the prospective cohort study of 85 patients has shown association of the high-risk obstructive sleep apnea with the severity of thyroid eye disease using the stop bank survey. So the aim of this our study is to evaluate the association between the obstructive sleep apnea and the thyroid eye disease activity using a stop bank survey. A stop bank survey is a questionnaire. So the study design of this study is basically the multicentric study with the prospective case control study. The all patients were taken from the duration of the January 2020 and December 2021. In the case groups, 100 patients were included, and in control group, 116 patients were included. So the in case group, the all newly diagnosed patients of the thyroid disease have been taken, and in the control group, the age, gender matched patient not having any sign and symptoms of thyroid eye disease have taken. So in the thyroid eye disease patient, we have done all the thyroid eye workup according to the BIJA classification system, and in the control group, we have done the normal ophthalmological examination, and the both have underwent to the OSA scoring using that stop bank survey. And then high risk of OSA considered when the score is more than and equal to 3, and in the low risk when the less than 3. So analysis for the both groups, we have done the parametric and non-parametric test for using the chi-square test and t-test and Mann-Whitney test. And the further inflammation score and activity and severity is compared within the case group. So this is the stop bank question consists of the 8 questions based on the snoring, tiredness and observed choking, blood pressure, body index has more than 35, age more than 50 years, and neck circumference more than 40, and gender. So it has high sensitivity and specificity and considered to be a good questionnaire for the OSA skin. So coming to the result in our study, the mean age is like comparable in the both age group. The gender is also comparable in the both age group. The hypertension and diabetes also we don't find any significant difference in the both group. Although in the coming to the OSA, when the case there is a in the high risk patient, the 61 patient in a high risk category, and in the control is the 39. So it is coming to the significant. And also there is an important history of the smoking exposure that is more in the case, and it in the control is the 6th. So it's also coming significant. So this is the significant difference in the both age group, both groups noted for the OSA scoring. So this is OSA score so significant is associated with the thyroid activity on Mann-Whitney test. However, with thyroid severity, it has shown some association, but although more than 5% percentage. So inflammatory scores on BIJA shows significant association with OSA group, and this table demonstrates that. So coming to the discussion, this study demonstrates that the prevalence of OSA is significantly higher in the patient with the thyroid eye disease compared to those without thyroid eye disease, and also had the significant association. So Godfrey et al. Has shown that this is the OSA patient is associated with the development and increased maximum severity of the clinical features like the thyroid compressive optic neuropathy, vertical strabismus, diplopia, conjunctival redness, chemosis, upper and lower eyelid edema, and eyelid edema by using regression analysis. However, B could not identify any clinical features associated that significant. So at present, we know that this is, we all know that the smoking is the only modifiable risk factor, and OSA can be another modifiable risk factors. So there are some studies in which the role of OSA treatment has highlighted the preventing the progression of vision-treated condition like the NAIN and the diabetic retinopathy. And its stop bang question is also already validated. So limitation of this study is there is a small sample size, multi-centric study that can lead to the subjective bias while doing the assessment of the clinical feature. And significant difference on the smoking exposure in the case and control group can be a possible confounding factor, because we all know that smoking also affects the OSA. So conclusion is that OSA has a significant association with the activity and inflammatory scores of the thyroid eye disease. Further study and impact of the thyroid eye disease should be done based on the polysomnography test, and also we should study the effect of the treatment of OSA on the course of the thyroid eye disease. And I personally feel that after this study that all thyroid study patients should be universally screened for the OSA. Thank you.
That's a good subject, but I think smoking should have been considered.
So ma'am, that is actually limitation, because when they do the case control, we can't match everything like, so actually
that's the major confounding factor, I
yes.
think. Yeah.
But okay. Ma'am, that when we did a analysis in our case group, so that shown the OSA score with the activity and the severity significant. So that where confronting does not come.
Okay.
Another question is that you have taken all the newly diagnosed cases of thyroid eye disease, and what was the mean stage of those cases? Like they were in which stage?
Sir, maximum cases were like, I will say, in the mild.
So I think that has got some relation, no? Because in other studies also they have taken severe cases of thyroid eye disease.
So, but sir, only because there only two studies have been done on this.
I know, but definitely that will have some implication.
Yes, sir.
A mild case and a severe case, they cannot go together.
So, but sir, we could not find for the compressive optic neuropathy and the OSA score, we could not find that association in with our sample size.
But you have not compared that also, no?
Severe
cases and mild cases, and you have taken those things in your account?
Yes, sir. With all the clinical feature, that thyroid compressive optic neuropathy compared, but we could not find that association like the Habib et al. Has found.
The other thing is, have you taken in account hypothyroid and hyperthyroid patients?
Yes, sir. All the blood like euthyroid, hypothyroid, hyperthyroid.
So any relation of
OSA,
OSA, but
significant.
You have not discussed that in your parameters, no?
Yes, sir.
Because in hypothyroid patients, we think that there may be more chances of OSA,
because of that,
because of more parasympathetic drive.
Yes, sir.
But in hyperthyroid patients, we think that chances of OSA may be little lesser because of sympathetic drive.
Yes, sir. Absolutely.
So I think those are the important factors
that
which you could have taken in your study.
Thank you, sir.
All right.